The American Society of Transplantation is proud to present the latest installment of the AST Journal Club series. Today's session features the Journal of Heart and Lung Transplantation article, Reproductive Health After Thoracic Transplantation, an ISHLT expert consensus statement. This session is co-hosted by AST's Women's Health Community of Practice and the Thoracic and Critical Care Community of Practice. In a moment, I will turn the session over to our moderator, Dr. Deborah Levine from the Stanford Lung Transplant Program in Stanford University. However, before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded, and the archive will be available on the MyAST website 2 to 3 business days after the live session. Please note that your lines have all been muted so that only the presenters can be heard clearly for the archive recording. If you have a question for our panelists during the journal club, we encourage you to participate by using the Q&A button in your Zoom webinar panel. Questions submitted via the chat window may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the website following the journal club. Finally, when you log off at the conclusion of today's journal club, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to our moderator, Dr. Levine, to begin today's presentation.
Thank you so much. Thank you, Brian, and all of AST for bringing us this great Journal Club webinar. And again, thank you from the TCC, COP, as well as the WHCOP for introducing us to both of our speakers and to this great journal article. Today, we'll be talking about reproductive health after thoracic transplantation, an ISHLT expert consensus statement, and our two faculty today are both co-authors on this document, which was actually published just in October of 2022. So it's hot off the press and so pertinent to all of us in thoracic transplant. So without further ado, I'd like to introduce our faculty, Dr. Michelle Kittleson, who's a professor of cardiology. She's an MD, PhD at the Smidt Heart Institute at Cedars-Sinai and a heart transplant cardiologist. And then for our second speaker, we have Dr. Vicky Gerovasili, who's a consultant in respiratory transplant medicine at Harefield, UK, and she's also an honorary senior lecturer at the Imperial College of London. We'd really look forward to hearing both of these, both of the lectures, and of note, we'd also like to thank the Transplant Pregnancy Registry International, where, as you'll see from both Dr. Kittleson and Gerovasili, that a lot of the data from their statement came from this international registry. So thank you so much, and we look forward to hearing from both of you. Dr. Kittleson?
Thank you so much. I'm delighted to be here. Thank you for the opportunity. It was my great honor and privilege to have chaired this statement, so I'm excited to tell you more about it from the heart transplant perspective. Let's go through our conflicts of interest disclosure. So Dr. Levine has none, and nor do I. Because everything is more interesting when we talk about a patient, let's begin with a case. A 35-year-old woman, heart transplantation 2 years prior for non-ischemic cardiomyopathy, presents to discuss whether she may become pregnant. She feels well, exercises by walking 30 minutes daily, no rejection, no donor-specific antibodies. Her medications include tacrolimus, mycophenolate, and amlodipine. She's been successfully weaned off prednisone at 1 year after transplant. 2 months prior, an echo showed normal left ventricular function. Angiogram demonstrated no evidence of coronary disease. How do you counsel this patient? Well, the good news is you now have a resource to help figure out how to counsel this patient, this reproductive health after thoracic transplantation, ISHLT expert consensus statement. And I'd like to point out that this statement is truly a phenomenal, multidisciplinary and multinational collaboration where experts in heart transplantation, lung transplantation, obstetrics, psychosocial health, and pharmacy got together from around the world to put this together. So when you think about how we counsel our patients, there's 3 phases to consider. What do you tell them before pregnancy? What should you do during pregnancy? And what happens after pregnancy? So before pregnancy, we think about preconception counseling, contraception, evaluation of safety of pregnancy, planning pregnancy. During pregnancy, we think about what should the monitoring plan be? How do you manage comorbidities? What's the safety of medications? And then after pregnancy, thoughts about breastfeeding, contraception, and return to pre-pregnancy immunosuppression. So let's dive in with what happens before pregnancy. Let's start with the 5 important factors in preconception counseling. If there's anything you remember, is that preconception counseling starts really when the patient is going through the heart transplant evaluation process, and it all focuses on the importance of shared decision-making, giving your patient the facts so you can come together on what's best for them. So pregnancy intention, contraception, timing of conception, what are the maternal and fetal risks, and how can you best offer psychosocial support? So we're going to take a deeper dive into contraception and maternal and fetal risks. There's a lot of options for choices of contraception in heart transplant recipients. The intrauterine devices are in fact the preferred method because they offer long-term, highly effective contraception. Immunosuppression is not a contraindication. There's not a concern for drug-drug interactions and straightforward for removal for reversal. The depot medroxyprogesterone acetate is highly effective, but there can be delayed return to fertility after cessation and the risk of decreased bone mineral density, which can also, of course, happen with corticosteroids. Combined oral contraceptions should be avoided in multiple situations that may coexist in heart transplant recipients, like coronary artery disease, hypertension. Also, if there's concern about risk of thrombosis, liver disease, estrogen-sensitive malignancies, you have to screen for hypocoagulable states before initiation, monitor immunosuppression levels. It goes without saying that barrier methods are not recommended as the sole method of contraception, not reliable enough, but should not be forgotten for used for protection of sexually transmitted diseases when indicated. How do you evaluate maternal risk? Well, we think about timing. When is it okay to become pregnant? And the general expectation is that heart transplant recipients will wait at least 1 year so that they have stable immunosuppression levels. They have not had any complications. They've demonstrated good adherence with their regimen. Indications for transplant may impact the evaluation of maternal risk. Peripartum cardiomyopathy, for example, has an increased risk of rejection and graft dysfunction, and heritable conditions that led to the mother's transplant may have impact on the fetus, and genetic counseling may be warranted. The requirements for graft function to optimize pregnancy outcomes and minimize risk would be normal LV function, no history of rejection, no allograft vasculopathy, no donor-specific antibodies. And the comorbid conditions that need to be controlled would include hypertension, diabetes. There should be the absence of severe renal dysfunction, proteinuria, and no active infections like CMV. And so where does some of these criteria come from? They come from the studies that have been done with our outcomes of pregnancy in heart transplant recipients. So we have multiple series that, and with a number of pregnancies, to tell us how do moms do? Well, graft loss is relatively uncommon, as is rejection. Live births in anywhere from 70 to 90% of cases, though the risk of spontaneous miscarriage still exists, as does low birth weight, premature delivery, and cesarean section. So when you think about outcomes of pregnancy in heart transplant recipients, there's no such thing as a free lunch. Rejection and mortality may be uncommon, but preterm and low birth weight is common, and a sobering statistic that 33% of mothers die an average of 9.4 years post-pregnancy, which just speaks to the overall prognosis of heart transplant recipients, and it's an important factor to take into account during those shared decision-making discussions. But if you get to the point with your patient that you have come together to a consensus that pregnancy is desired and medically appropriate, then you need to adjust immunosuppression. And this should be done pre-pregnancy. Pregnancy should be planned, if at all possible, thus contraception being so critical. Corticosteroids are generally safe. Cleft palate may occur with high doses in the first trimester, but is not a major concern. Calcineurin inhibitors do not have teratogenic potential in human registries, but frequent monitoring may be warranted due to the changes in volume of distribution and metabolism during pregnancy. Antimetabolites are 100% contraindicated. There's a teratogen. There's the risk of spontaneous abortion and congenital malformations from mycophenolate. This should be discontinued 6 to 12 weeks before planned conception or immediately if pregnancy is unplanned. And proliferation signal inhibitors, there's limited data. Generally, it's recommended that these should be stopped before planned conception or immediately if unplanned, but the data is not as strong as for mycophenolate. So moving on then to what happens during pregnancy, your monitoring plan, your comorbidities, safety of medications. Well, as we recommend in the consensus statement, graft function should be assessed with vital signs, exam, ECG every 4 weeks, an echo every 1 to 2 months, and then monthly, CNI levels every 4 weeks and then more frequently as delivery nears, and HLA antibodies after delivery to ensure no new sensitization. As far as comorbid conditions, checking the basic metabolic panel, liver enzymes, urinalysis is important to look for pregnancy-related issues, fasting glucose tolerance test, and of course, looking for infections. The fetal growth will be monitored, of course, by the obstetrician and often in conjunction with a high-risk obstetrician and or a maternal fetal specialist with a transvaginal anatomy ultrasound if available and obstetric ultrasound after that. Hypertension is hugely common in heart transplant recipients and even more so during pregnancy. And what do we think about as the safest antihypertensive medications? Well, nifedipine, first line safest, methyl-dopa safe but can have side effects. Hydralazine, the 3 times a day dosing may limit adherence. Diuretics should be avoided, and labetalol, while safe, may not be tolerated as well in heart transplant recipients due to the risks due to denervation of the transplanted heart. When it comes to obstetric considerations, folic acid is initiated prior to planned conception, and aspirin is often used as a prevention for preeclampsia. And cesarean births are reserved only for obstetric indications or in the event of intractable heart failure. Otherwise, a vaginal delivery is recommended. So moving on then to what happens after pregnancy, breastfeeding, contraception, and pre-pregnancy immunosuppression. Well, the considerations for breastfeeding are about the same as they are for pregnancy. Corticosteroids, calcineurin inhibitors, fine. Antimetabolites are not recommended, and there's question mark for the proliferation signal inhibitors. This is a fantastic resource if you're ever unsure of what's right for your patient. The LACT-Med database is a resource where you can put in the drug name and see all the information that exists regarding potential safety or danger. So if we go back to the patient we started with, well, she's over a year out from transplant. She feels well. She's had no complications. She's got normal graft function, no allograft vasculopathy. I think you would counsel this patient that pregnancy can be safely considered. So in summary, preconception counseling starts during the transplant evaluation. IUDs are the preferred method of contraception. Contraindications to pregnancy would be being less than a year post-transplant with abnormal graft function or uncontrolled comorbidities. Monitoring of graft function, comorbidities, and infection is required throughout pregnancy. And remember that the safest and immunosuppression in pregnancy and breastfeeding are corticosteroids and the calcineurin inhibitors. And I'd like to thank the many members of the writing committee who were amazing resources to put together this document to provide the best care to our patients. Thank you so much. And I'm going to turn it over now to my colleague, Dr. Gerovasili. You're on mute.
Thank you very much, Michelle. And it's such a pleasure to be joining all of you this evening for the UK, afternoon, I think, from the other side of the Atlantic. I will build on Michelle's presentation, presenting the information in this consensus statement, but with a focus on the lung transplant recipient. And there will be some duplication, but I will try to avoid as much as possible, because there are certain common themes, but there are also many differences as well. I have no relevant financial relationships to disclose, and the outline of my talk will run through the same themes that Michelle's presentation ran through. So preconception counseling, contraception, but with special considerations in the lung transplant recipient, and then pregnancy planning, timing, risk assessment, and the baseline assessment, along with special considerations again in the lung transplant recipient. And finally, pregnancy outcomes and the data that we have in lung transplantations, as well as monitoring during pregnancy. Now, when does preconception counseling start? As early as possible, I think, is the answer, and that's the vibe, the guidance from the consensus statement. And it should start before transplant, during the beginning of the transplant journey, and during the transplant assessment. And it should continue early after transplant, even before discharge, after the transplant episode, and then annually thereafter. Fertility can come back very early on after transplantation. There are reports of pregnancies 1 and 2 months after transplant, so it's certainly not too early to start immediately after transplant. But even before, parenthood and family planning is such a big part of our patients' lives. And they do have a transplant, and one of the promises we give them is a normal life or a quality of life. And for some of them, parenthood is part of it. It's not a couple of months ago that I was assessing a patient with cystic fibrosis for their inpatient assessment to go into the transplant waiting list. And we do have preconception counseling as part of our structured interview. And the most important thing that patient wanted to discuss with me was if she could have babies after her transplant. And our discussion played a big part in the decision that she made. And it is important to discuss, because as a medical community, we do fail. 50% of pregnancies in the lung transplant recipients are unplanned. And that's a failure of us discussing with our patients, and for our patients knowing that they should be and they could be discussing with us. And we can be of help to them in planning their pregnancies. And we can avoid that by discussing contraception and other options, which could include surrogacy or adoption. And we've certainly had patients that I look after that opted for a surrogacy after having a discussion with her transplant team. One of our patients became a mother via surrogacy last year. For patients with cystic fibrosis, genetic counseling is important, and that's something to be factored in when they are thinking about the pregnancy. And we would like their partner to be involved in that decision-making process, and I will talk a little bit more about that later on. But it's also about understanding the risk of that particular patient and counseling them about that risk and what that could mean to their pregnancy and their life afterwards. But before we say anything more, let's meet Sonia. Sonia is one of our transplantations. She's currently 21 years old. She has cystic fibrosis. She's 4 years post-lung transplant. Her graft function, her FEV1 is in the region of 2.2 to 2.3 liters, and I will show you a graph of her lung function in a minute. She had 0 episodes of acute rejection. She did have 1 episode of organizing pneumonia fairly early on, which required some steroids, but nothing since. And she has the usual comorbidities, or the common comorbidities of a patient with cystic fibrosis. So she has CF diabetes. She has a history of DIOs and constipation. She has started a CFTR modulator in collaboration with her CF team. She also has reflux and had a Lynx device inserted in 2022 to control that. Sonia came to clinic last year and expressed a very strong wish to become a mother, and she had had a miscarriage the year before. We will come back to Sonia a little bit later in this presentation. This is her lung function from the time of transplant onwards. The orange line is her FEV1, and you can see how it's remained stable for 4 years. Now, Sonia is 4 years after transplant, but what is the timing that we should start thinking about or recommending pregnancy in our transplant recipients. And there isn't a lot of literature out there, and one of the discussions in the consensus statement was recognizing the lack of data, the considerable higher risk of rejection in the lung transplant candidates, especially lung transplant recipients, especially early on after transplant, as well as the higher level of immunosuppression required to maintain graft function in the lung transplant recipient, all of which play a role in the timing of transplant. The consensus was that to consider pregnancy, a patient should be 2 years post-transplant, or it could be more if the graft has not stabilized for the first 2 years. And it's not only about the graft. This is a figure taken from the consensus statement. And there are 4 elements in that graph, and we will go through all of them in the next few slides. But we do need to think about the graft and how stable it is, comorbidities of the mother, and obviously pharmacological considerations. Some of them are very specific to the lung transplant recipient, as well as hereditable conditions. So that forms these 4 elements form the baseline of the risk assessment and the pregnancy planning in the lung transplant recipient. And to dig a little bit more deep into those elements, the history of the patient, things to think about is this a genetic condition? And in the lung transplant recipient, it's mostly patients with cystic fibrosis who form that younger cohort of patients who are most likely to pursue parenthood after lung transplantation. And in the history of cystic fibrosis, obviously, or certain congenital heart conditions comes genetic counseling. For patients with cystic fibrosis, we do need to think about the nutrition status. And for all patients, lack of adherence is a relative contraindication to pregnancy. There aren't really, I hesitate to use the word contraindication, because we are there to support our patients and to help them make informed decisions. But certainly, non-adherence is a significant risk factor. Comorbidities that have many similarities to Michelle's presentation, and there are many similarities in both cohorts with diabetes, hypertension, and chronic kidney disease, especially with an eGFR of 30 or less, or associated proteinuria, are risk factors for adverse events during pregnancy. And uncontrolled diabetes and hypertension and a GFR of less than 30 would be a contraindication to transplant to pregnancy in a lung transplant recipient. And then the next thing is the graft function. And the things to think here is there any history of chronic rejection or CLAD, antibody-mediated rejection or acute rejection? And if there are any episodes of those in the last few years, those would be a contraindication to pregnancy, putting that patient in a much higher risk. And obviously, you would like, or we would like, to assess the graft function when discussing pregnancy or planning pregnancy with our patients, and that includes the usual baseline investigations that are sensible to any clinician, so assessing FEV1 and the baseline chest X-ray, the presence of any HLA antibodies, and that can form the baseline from comparison in case there are new DSAs after pregnancy, which can be a triggering event. But also any investigations that need to be completed, such as bronchoscopy, if indicated, or microbiological surveillance, cultures, again, if indicated. All of that should be part of pre-pregnancy planning, so that the patient, the future mother, goes into her pregnancy with her comorbidities controlled, with a stable and well-investigated graft function, with an opportunity to have discussions around genetic counseling, and then obviously to ensure that all immunosuppression or medication that need switching or discontinuation can be done in a planned and safe way. And that also includes, obviously, supplementation such as folic acid. I will not go into the details of that because there are the same elements that Michelle has talked about in her presentation. But I would like to take you through another patient story. This is Alice. Lung transplantation is not the same as heart transplantation or abdominal transplants, kidneys or livers. The lung graft is at higher risk of rejection, and that includes antibody-mediated rejection. And we know that pregnancies are a triggering event. Alice is a patient with cystic fibrosis, and this is a graph of her lung function over time, starting from 2011-12 up until today. And where you see the pink arrow is when Alice had a miscarriage, so had a pregnancy and a miscarriage. And then a few months after that, we detected new onset DSAs, and she developed clinical AMR with a drop in her FEV1, as you can see in this graph. And it was a very, very, very worrying time for her. It was an unplanned pregnancy and a very, very worrying time for us because we were clearly losing her. She has done well and she has stabilized, but that is an example of how a pregnancy can put our patients at risk. I think it's worth having some thoughts that are specific to patients with cystic fibrosis because they do form the largest group of patients, and the things that come to mind and are described in those guidelines in patients with cystic fibrosis are the presence of diabetes, which should be well controlled. It's important to think about malabsorption in this patient cohort and how things can change during pregnancy. And that includes primarily fat-soluble vitamins, with special consideration to vitamin A, which should not be more than 10,000 units. Patients with cystic fibrosis can have reflux or gastroparesis, and especially gastroparesis, well, both actually, can be exacerbated by pregnancy due to the circulating hormone levels, and then later on due to the pressure from the growing uterus. And obviously diabetes, if it's not well controlled, will play a role there. And then another element is the psychosocial factors around patients with cystic fibrosis or lung transplant recipients overall, if you like. The median survival of a lung transplant recipient is 9 years, and that is conditional to survival of 1 year. And we do need to prepare our patients and have these very difficult discussions about how it would feel like to raise a child when they may not have a child, when they may not see it grow up, or they may have declining health and the child to look after. But also would like to bring in the CFTR modulators, which have completely transformed the world of cystic fibrosis. And in patient fora, many of you will have heard they are termed as the fertility pill. And our lung transplant recipients see their peers who have not had a transplant have a better lung function, a better quality of life, and start having families. And they will be coming more often to us. That's certainly what I see in my clinic, asking for a family and asking for a chance at parenthood. And we can't ignore the environment around us and around our patients. And obviously genetic counseling, as already mentioned. Now, there isn't a lot of data out there when it comes to pregnancy outcomes in the lung transplant recipient. And I should also give a shout out to the TPRI registry, where we get the most information. There are only 3 sets of data, 1 registry and 2 publications that have more than 10 patients. And there are some smaller case series and case reports. But cumulatively, it's around, in these 3 cohorts, at least around 100 patients or 100 pregnancies. And half of them are unplanned, as already mentioned. There is a small risk of graft loss, up to 5% within 2 years. The maternal death during pregnancy is low, but there is a risk of rejection, which is up to 40% in one study, or 33% in one study after pregnancy, which is not negligible. And the sobering number of maternal survival of 4.6 years, mean survival after the pregnancy. So I guess, again, to summarize the current evidence or the current data out there, around 100 lung transplant recipients having had babies, half of them were unplanned pregnancies. Maternal death during pregnancy is rare, but rejection either during or after is not uncommon. One in 20 of those mothers lost their graft within 2 years, and the mean survival after the pregnancy was less than 5 years. Babies, on the other hand, more than half of pregnancies, between 42 and 67%, resulted in a live birth. The babies tend to be premature, with a mean gestational age of 34 to 36 weeks, and a low birth weight. More than half of them were preemies, but overall, they did not seem to have significant congenital malformations. And that's important information for our patients to have. Monitoring during pregnancy is not dissimilar from what Michelle has talked about. So it focuses around the graft function and the management of comorbidities. The recommendation from the consensus statement is for monthly visits, clinic visits or examination, and monthly spirometry. And it's worth remembering, and as it's highlighted in the statement, that the FEV1 does remain stable during pregnancy. So any drop should be attributed to the graft function and not to pregnancy itself. Immunosuppression monitoring, the recommendation is monthly until 32 weeks, then every 2 weeks until 36 weeks, and then from then onwards until 1 month postpartum weekly, because of the big volume shifts that happen towards the end of pregnancy and in the postpartum period. And then measurement of HLA antibodies 1 to 3 months postpartum. Comorbidities is monitoring of renal function, liver function, diabetes, and infection, as already mentioned. Now, how did my discussion with Sonia go? Well, we discussed if her lung function and her graft function was stable. I spoke to her how likely is that to change during her pregnancy. I did tell her that there isn't a lot of data out there, but I would try to give her an estimate as best as I could from the information that was there. We discussed what other conditions she had that could put her at risk. Sonia had a discussion with her CF team about the CFTR modulators. She chose to stay on them. We discussed her reflux, her diabetes control, and we've adjusted her vitamins, and she started folic acid. She wanted to know about the risks to her baby, and we did discuss the genetic counseling. And it was important for both partners to know that they may not see, one of them, the mother may not see the child grow up, and the partner might need to raise a child alone or with a partner in declining health. But at the end of the day, our role, as I see them at least, as I see it, is to support our patients in a shared decision-making. And if that was Sonia's decision, then I would offer her monitoring and medication changes, and we would liaise with her CF team and the obstetrics teams to make sure she has that MDT input that we think is required. And obviously, psychology support would be a big part of what we would like to be offering Sonia. Sonia is currently 25 weeks pregnant. She's due in June. And with that, I have finished. Back to Dr. Levine.
Wow, thank you both so much. I think we can all come back on the camera. And those were fantastic lectures, as well as really a good outline of what's in the document and some of the actual criteria guidelines that are given. And it was interesting that many of them are the same, but there was a couple differences between heart and lung, and love to hear more about that as well. I think we have a lot of questions already in the question and answer. And if you do have any questions for our panel, please put it in the question and answers. And we have several good ones. I was going to start with one from the audience about, which is a great question for both. Can you both comment on IVF after thoracic transplant?
Sure. I'll start with the heart transplant perspective. And I think it's a really important question because difficulty with getting pregnant is very common. And actually a TPRI registry analysis, about a quarter of patients may report difficulty with pregnancy. So if you're thinking about assisted reproductive technology from a heart transplant perspective, number one, are they safe to get pregnant in the first place will be important, though they may decide to use a surrogate, and that may be part of that equation. If they are either using a surrogate or safe to get pregnant on their own, the next question is, well, what's the risk of ART? In fact, in registries in the general population, there's a very low risk of thromboembolism, so we worry less about that piece, though I think more caution might be exercised if you have a transplant recipient who's had issues with thromboembolism. And then the next issue would be, well, what about the risk of multiple gestation? So I think you would have to counsel the reproductive endocrinologist, obstetrician, that you would want implantation of as few embryos as possible to avoid the risk of multiple gestations, which increase the risk of hypertension, eclampsia, preeclampsia. And then the last issue, there's this theoretical risk of ovarian hyperstimulation syndrome when you give a lot of these assisted reproductive technologies, which can lead to fluid shift. But I would say if the transplant recipient has normal cardiac function at the start of the process, likely they could withstand that. So it comes down to understanding the risks and going through those with the patient: small risk of thromboembolism, small risk of ovarian hyperstimulation syndrome, as well as multiple gestation. But if those things are appropriately managed or vetted, then we would encourage the patient to proceed.
Thank you. Any differences for lung, Vicky?
I don't think so. I would have said the exact same things. Funnily enough, I have had experience with one of our patients who was planning a pregnancy through surrogacy and did get overstimulation syndrome, which was not pleasant, but manageable and certainly easier when the transplanted organ is the lung and not the heart. But I don't think there are differences here.
Probably the one time ever it's easier with a lung transplant than a heart transplant.
One follow-up question. Oh, did someone have a question? One follow-up question relating to this is, in terms of looking at talking to patients pre-transplant, that's, preconception and pre-transplant, looking at freezing eggs, for example, prior to, that is usually done as an outpatient procedure, and at least for our lung patients, and most likely for cardiac patients as well. They're not the most stable patients, to do this. So when we're talking about surrogacy or anything like that, have you dealt with this issue, and how is it both in the US and in the UK?
I would say, it's interesting. I think our demographic undergoing heart transplant is probably a little different than yours undergoing lung transplant. Our patients tend to be older and they tend to be male because one of the most common indications is ischemic cardiomyopathy, from coronary artery disease. So it's less likely for us to have these young women who would be contemplating something like egg freezing. So I have not personally encountered that situation, nor have I seen reports in the literature, but it's exactly as you said, Deb. It's about how, and sometimes their graft function is more stable after transplant to tolerate the hormonal shifts than they would be pre-transplant. Also, there's often cardioembolic disease in the setting of the failing heart that might be a concern. So that's a great point. I'm very interested to hear how it differs in lung transplant.
Well, it's certainly a younger demographic, and the vast majority of patients would be patients with cystic fibrosis. And actually, the discussion does come up fairly often. And I have had patients who have frozen their eggs before they had their transplant. I have also had male patients, because fatherhood is part of the discussion, who have chosen to, well, at least one that I can remember, who have chosen to freeze their sperm before transplantation. I certainly experience of that post-transplant where the graft function is usually much better, so it's less of a concern. It hasn't happened to me so far that a patient who has cystic fibrosis is before transplant has been unable to get to go ahead with egg retrieval. But it as with any procedure pre-transplant with a low graft lung function, it is a concern, of course, but it is a discussion that comes up, and it is part of our structured discussion pre-transplant. So we bring it up even if they don't.
No, I think that's great. And I think when you're talking about all forms or all modalities to help patients, looking at everything and really being able to have that. I love that idea of the multidisciplinary team, pre-transplant and really in counseling, both for the patient and their spouse or their partner, to talk about the options and really what may be coming forth after transplant. There's another question that came from, this really high quote that you talked about. I'm not sure if it's both for heart and lung, but and if they were in the TPRI registry, was this fact that there's 50% of pregnancies were unplanned. And do you think that's secondary to the fact that, we need to really be coming as a community and talking about pre-transplant and really follow the guidelines you all discussed in this document to really come up with, hey, we should all be talking about this in a structured manner prior to transplant? And what are your thoughts on that?
I think it's a failure of us as medical professionals looking after our patients. 50% of pregnancies being unplanned. I think it's on us. We should have had that discussion with our patients repeatedly or as often as they need it. And they either didn't think that we would listen or we didn't ask in the appropriate way. Or we tend to focus on how the lung is working and what the medication levels are and what the creatinine and urea level is and what the CRP, and tend to forget that these are people living in the society. And it's not only about those numbers, it's about their psychology support, their return to work, their introduction, if you like, into society, and parenthood is part of that. But it's a difficult discussion to start.
Would you have the discussion, do you both or have a special high-risk GYN, high-risk OB that is involved in your in these pre-counseling sessions, that you have kind of like a go-to transplant person that kind of can work with you to make this more standardized into your center?
So we don't have it as we have so many pre-transplant checklists, right? I mean, you get the colonoscopy and make sure they're the chest CT and the CMV IgG. It would be so nice if this was a box, preconception counseling. I'm thinking we should probably add that to our transplant list of things we do pre-transplant. And we don't, at this point, send patients to someone, but yes, there is a go-to high-risk OB/maternal fetal medicine team that is willing to swoop in when we alert them. We have a patient who's interested in potential transplant that we feel medically it can safely proceed to meet with and take the next steps from the obstetric standpoint.
And even talk about contraception as well, correct?
Yes. Yeah.
Because that's even if they were not going to consider having going ahead and getting pregnant, they would want to, that would be a kind of a topic that could be discussed in that pre-transplant counseling session. I love your MDT concept within this guideline. We have a question that actually also came up prior to this, and really it's discussing, and I'm going to add both heart and lung in this. What is your experience with the use of azathioprine as a substitute of mycophenolate and I'm going to add lung because I'm interested as well in thoracic transplant?
I'm sure the answer is going to be different. So I'm going to say heart transplant recipients, we know in general have a lower risk of rejection. We know, especially if you're a year out and stable with no rejection and no DSAs, you're in good shape. And so our conception in that, or our perception is that a corticosteroid plus a CNI is absolutely safe And the added benefit you would get from rejection prevention with azathioprine is so minimal, we wouldn't bother to give it. And then there's also potential risks of the myelosuppression infection. So in a heart transplant recipient, we almost consider azathioprine of detriment rather than benefit when it comes to infection prophylaxis, and only use it in the rarest of situations of patients with prior Chagas disease and potential reactivation based on South American observational data. And in no other situation. So I would say for heart transplant recipients, CNI plus corticosteroid, the way to go. And if you think your patient's not stable enough to handle the CNI corticosteroid, and you think, oh, they'll need azathioprine to hold them safe, then maybe they're too high risk that transplant should be a viable medical consideration.
Interesting.
It's not as easy in the lung transplant recipient, is it? But I don't have an answer that would fit all. So our approach is to have a more of an individualized approach. So certainly we could stop MMF. That's an easy one. Most of our patients are maintained on a CNI and MMF and corticosteroids. But we do have a percentage of patients, especially those that early on had a higher risk of infections, that we maintain on two immunosuppressants, CNI and steroids. So we are fairly relaxed and a bit more confident in maintaining patients into immunosuppressants, but that does depend on the patient. So Sonia, for example, who is a real patient, we opted to stop her MMF, and we did not start her on azathioprine. Other patients previously, based on their history and timing after transplant and other individual factors, then we would have started azathioprine to replace MMF. So I don't think there is a one shoe fits all answer.
Thank you so much. We have a really, in one of these unplanned pregnancy situations, we do have a good question, and this is for heart transplant recipients. When do you advise an abortion after pregnancy? Are there conditions that place the transplant patient or recipient at higher risk than the non-transplant recipient? For example, new high DSAs without LV dysfunction or anything else?
Yeah, I mean, that isn't a plug more than anything else for the importance of contraception. I mean, because no one wants to have that discussion with their patient. No one wants to have the, I think you should terminate this pregnancy discussion. And it's really hard to put absolute criteria for which to recommend pregnancy termination, because we're dealing with small numbers, and it's really hard to identify what are the risk factors for a maternal catastrophe versus no. But I think we'd all say graft dysfunction is a big one, and significant allograft vasculopathy, grade 2, 3, and or restrictive physiology would be a really concerning situation. But what about that situation you brought up? The LV function is okay, but you're seeing a de novo DSA at high levels, so something is waiting to go wrong. And if you back off on immunosuppression in order to let them get safely through pregnancy, is something going to go even worse. So how I would put it to the patient is, I can't predict the future, but I'm very worried that this situation is being set up for something bad happening to you. The safest thing to do would be to terminate this pregnancy, so I can augment your immunosuppression by initiating a PSI, perhaps putting you through some more intensive anti-antibody treatments like IVIG, rituximab, tocilizumab, etc. And if you don't want to do that, if you feel so strongly you're willing to accept these risks, we'll be here for you, but we're very concerned. That's how I would put it.
A question I have about monitoring post-transplant in terms of CNI levels. I see that the guidelines talk about up to 32 weeks, you're checking monthly, and then after that, 1 to 2 weeks. And I had the experience of finding my TAC levels being incredibly low, much earlier than 32 weeks. And I wondered how the group came up with this time period or point of really looking at the levels much more closely.
Yeah, it's a great question. And I think it comes down to, and perhaps we specify this, or perhaps we should have, that it all depends on what your levels are. I mean, if your levels are stable, every 4 weeks may be okay, but if you get a low level, you can't wait 4 weeks to recheck, you're going to end up doing it more frequently. So I think your point's well taken, and certainly doing it more frequently. If you're at all concerned, if the patient has been one that has run on the lower end, then I think you're absolutely justified in doing it baseline every 2 weeks or even more frequently.
Excellent. And along the same line of monitoring, we have a question that really not sure if everyone's talked about in the past, but is does anyone utilize cell-free DNA for graft monitoring? And we know that cell-free DNA was established first in pregnancy and then for other patients, i.e. Transplant recipients, but do you utilize this for monitoring pre and post pregnancy?
We don't because we worry that you'll get a false positive related to the fetus and not the heart. So it's actually, we recommend not utilizing donor-derived cell-free DNA because you don't know if it's donor-derived or fetus-derived, and you can't interpret the results.
Yeah, same here.
But a really good question. So thank you for bringing that up to us. Great question. You know, this is a hard one, and it's harder, especially I think in the lung field, but in the heart as well, and definitely much more difficult than in the abdominal organs, which I know the TPRI, you know, sees has a much higher numbers and much higher rate of pregnancies. But in our field, in our thoracic patients or recipients, how do you discuss life expectancy in the context of pregnancy, both before recipients are getting pregnant and after?
It's not an easy one, is it? And it's not, you can't pretend that it is an easy discussion. It's never going to be. But it is a discussion that needs to be had, I think. And the only way to approach it is with compassion and kindness and respect, because what I see as an acceptable lifespan or a relatively that justifies a pregnancy, if you like, is not the same way as it is perceived by someone else. So they have their own values, our patients. They have their support network, the people around them, and their own needs, and we are here to respect that. It's not for me to judge. That's how I approach it. But I do need to have that discussion with them. I do, and the patients know. They do know. I'm sure you have experienced how I have with the lung transplant recipients when they come to this 5-year mark post-transplant. Many of them tend to become very nervous because they sort of feel that this is their expiration date. It's awful to think about it, but it's true. And just because we choose not to talk about it doesn't mean that it isn't there and that they don't think about it. So it's a difficult discussion.
And Michelle?
Yeah, I know. You said it so beautifully. We have it a bit better in heart transplant. The median conditional survival after transplant, if you survive the first year, is anywhere between 11 and 14 years, depending on the registry you look at. Though we know that that the survival after pregnancy in at least one of these analyses was only about 9 years. So I think you're right. We have to bring it up, but as fact sharing. And what I often tell transplant recipients is, I don't think this should necessarily dissuade you from becoming pregnant, but you have to be aware of the options and have plans in place to care for your child. But you know what? Even if you are not a transplant recipient, you can get hit by a meteor when you're crossing the street, and it's really good to have a backup plan for the care of your kids. So I try to phrase it in that way. Let's control everything we can. We can't control how long you're going to live. We can't predict the future, but let's try to put together a plan where you're aware of your risks and mitigating them as much as possible.
I think that's a really good thought. And I, you know, this is such a kind of multidisciplinary portion of transplant. You know, it includes so many people, and I know on the guidelines that really you put together a great team, and those people that were involved in this should be probably thought of as a mini team at home for each program. And I think working together with both, just as the TPRI does with all organs, maybe working together. I don't know what you all think about this, but it doesn't have to be a lung transplant team or a kidney transplant team. It's, maybe including and creating some type of MDT or multidisciplinary team that would include all. And I think that was really well pointed out in your guidelines, and also it really shows up great from the TPRI. And I just want to shout out because this is co-produced or something by the TCC as well as the WHCOP. And actually today on the line, we have Lisa Cosilla, who is not only leads the TPRI, but also is the head of the WHCOP, or the chair of the WHCOP at the AST. So thank you for putting together the TPRI and working on this with your whole group. But do you, Michelle or Vicky, have any other closing remarks or questions?
I think I would just say if any, pregnancy is sort of this beautiful epitome of the triumph of science. That, oh my gosh, we actually are at the point now we can think about pregnancy in people who have this life-saving procedure where it's never been thought of before. And the second is, it's also a really great example of exercising all our muscles, both scientifically and medically and emotionally, to give our best to our patients.
Beautiful. And Vicky, I'm not sure if
I
there's
think pregnancy in the lung transplant recipient can have lots of challenges. It's a journey that will have ups and downs, but it's their journey, it's our patient's journey, it's their decision, and our role is to support them. And those unplanned pregnancies and the lack of discussions around contraception and pregnancy and counseling is where we fail them, and it's not that difficult to be better at it. And I hope this consensus guidelines brings that to the forefront of our minds and our planning as a team of how we deliver better care for the patients who ask for it. If 50% of them get pregnant without talking to us, they're clearly thinking about it, just not telling us.
And I think one more thing to really point out here is the topic of reproductive health is not just pregnancy. It's, staving, counseling against STDs and worrying, when can I start having sex after transplant? All these things are included in a whole realm of, or a topic that's a really, which a part of it or a subset is pregnancy, but also reproductive health in itself is such a big topic for our patients who are young and after transplant feel more happy and alive and looking into these things, where maybe when they were a sick PH patient or a sick CF patient, they really weren't considering. So I think it really, congratulations on such a beautiful document that will help for years and years. And really, we should all learn from it and keep it for all of us in our clinics and in our centers to look at for any type of help. And so, first of all, thank you so much for such a great lectures. And we will, I also want to thank AST, Brian and Olivia for really allowing this to occur. And thank you to WHCOP and all of TCC. And thank you for all the attendees and the wonderful questions that were brought up today.
Thank you, Dr. Levine. AST would like to thank Drs. Kittleson, Gerovasili, and Levine, and the members of WHCOP and TCC, as well as all of our attendees for today's session. Please remember to complete the evaluation survey that will appear after the session closes, and visit myast.org/journal club to view our video archives and register for upcoming journal clubs. To learn more about AST's WHCOP and TCC, please visit myast.org/COPS or connect directly to the individual COP hubs. Thank you again for today's session.